Good morning, folks. Let's get started. Can you guys hear me okay?
Yes.
All right, thank you. All right, guys. Today we're going to finish chapter 15, and we don't have a lot to go to finish chapter 15, so we're all going to be able to get out of here a lot earlier today, okay? And just to remind you, since we're going to be finishing chapter 15 today, the quiz for chapter 15 is open. In fact, it's open right now, and you're going to have until Sunday night to take the quiz. Okay? Do not forget to take those quizzes. So let me share my screen with you. And we have been talking about the urinary system. So we spent a lot of time on Tuesday going over the kidneys, talking about the nephron. We all understand that the nephron is the functional unit of the urinary system, right? And we also know that as the functional unit, the nephron is where the blood is going to be filtered and the urine is going to be formed. Now, as the urine is formed inside of the kidneys, this urine needs to get out. And the urine is going to get out through what we call the ureters. So we can see these two tubes right here. Okay, so we have the right ureter, we have the left ureter, and these are bilateral. So what is the ureter is going to do? The ureter is going to take urine from the kidneys and send it inside what we call the urinary bladder. Now, the urinary bladder's function is to store the urine. And inside the walls of the urinary bladder, folks, we're going to find a layer of smooth muscle called the detrusor muscle. And this muscle here, when it's time to empty the bladder, the brain is going to send a signal to the detrusor muscle because these muscles are involuntary. And now the detrusor muscles are going to contract and it's going to squeeze the urinary bladder and push the urine out through the urethra. Okay? Now we can see how the ureters, they're going to attach to the urinary bladder in these two little holes right here, these two little orifices. So this is the point of attachment of the ureter with the urinary bladder. Now, as we look inside the urinary bladder, we can see that we have a layer that is called transitional epithelium layer. Now, why are these cells called transitional epithelium? They're called transitional because they change shape. When the urinary bladder is empty, these cells, these epithelial cells, they have a cuboidal shape to them. They look like a little cube. When the urinary bladder is full and it expands, now these cells, they're going to have a squamous shape to them. They're going to be like flat, like a pancake. Okay? Now, the opening that we have right here at the junction between the urinary bladder and the urethra, and if you draw a straight line through those three openings, we get a triangular region inside the urinary bladder that is called the trigone region. Now, why do we care about this region here? Why are we even talking about it? Guys, the reason why we talk about this trigone region inside of the urinary bladder is because when someone has a UTI, a urinary tract infection, this is the region inside the urinary bladder where the bacteria is going to grow and propagate. Okay, so this is the site of a propagation of the bacteria. And when the bacteria starts to grow right here, then it's going to lead to what we call a UTI or urinary tract infection. Okay? Now let's take a look at the urethra, which is the final section of the urinary bladder right here. And the urethra is going to have two different sphincters controlling the flow of urine out of the body. We're going to find an internal urethral sphincter and we're going to find an external urethral sphincter. Just like we have two anal sphincters, right? We have an internal and an external anal sphincter. So we have an internal and external urethral sphincter. The internal urethral sphincter, guys, This one here is involuntary. We don't control it. Okay? Now, the external urethrosphincter is voluntary. This one we do control. All right? Now, I want everybody to look up here on the screen, folks. And we can see right here we have an X-ray of the urinary system. And we can see the formation of urine inside of the kidneys right here. And then we can see the urine flow from the kidneys into the ureter. And then from the ureter, the urine is going to flow inside the urinary bladder. Now, if you look on the left kidney, right here, so this is the left, this is the right, right? So if you look at the left kidney, we can see there is something obstructing the flow of the urine right there, guys. Does anybody know what that is? What do you think that might be, guys? Obstructing the flow of urine from the kidneys down into the ureter. See here? Kidney stones, absolutely. So what we're looking at right here on the screen, this is the formation of the presence of a kidney stone. And a kidney stone is also what we call a renal calculi. Okay, the renal calculi. This thing's stuck right here. Hold on. There we go. Now let's watch a little video here that shows how kidney stones are formed inside of our kidneys. And this is very relevant for us, all of us living in Hawaii, which is a place that is hot, is a place that is humid. So we have the perfect environmental situation here for us to develop a kidney stone. And the most important thing that you need to get from this slide, from this video, guys, is that if you are well hydrated, developing kidney stone is very, very difficult. Now, if you are constantly dehydrated, then you have a good chance of developing kidney stones. And let me tell you, I had the kidney stones before. It is not fun. It's probably one of the most painful things that I've ever experienced. Okay? So let's watch this video here.
A kidney stone can be as small as the head of a pin, almost invisible to the naked eye. But as every stone former knows, the pain resulting from this tiny crystal structure can be enormous. Inside kidney stone disease. Kidney stones, or renal calculi, are aggregates of crystals enclosed in a matrix that develop within the kidneys. They're classified according to the specific types of crystals they contain and fall into 5 major categories: calcium oxalate, calcium phosphate, struvite, uric acid, and cysteine. The most common is calcium oxalate. How is a stone formed? The first step is nucleation. Ions such as calcium and oxalate that have been filtered into the urine by the kidney spontaneously join together to form a solid crystal nidus. This is called nucleation. There are 2 kinds of nucleation. In homogeneous nucleation, crystals form around a nucleus with the same composition. Crystals of a different composition can also form around the nucleus. Organic materials, such as cell debris, may be deposited between the crystals as a matrix. This is heterogeneous nucleation. The tiny crystal formations travel down the nephron and are usually deposited at the renal papilla, where they undergo the next major phase, growth. Crystals that have already formed then begin to stick together, forming large aggregates. As we can see, crystals can aggregate very quickly. New stones are retained in the kidney, where they can continue to grow for an unspecified length of time until, for reasons that are not well understood, they are displaced and travel through the kidney into the ureter. If a stone continues to grow until it reaches a critical size, which can be as small as 4 to 5 millimeters in diameter, it may be too large to pass easily through the ureter. The edges of the stone may become wedged inside the ureter at the ureteropelvic junction, where the ureter crosses over the iliac artery, or at the ureterovesical junction. The result? Pain and obstruction until the stone slowly passes into the bladder and eventually passes out of the body in the urine stream. In the U.S., it is estimated that 13% of men and 7% of women will develop a kidney stone during their lifetime. Fortunately, in about 78% of these patients, stones will be expelled spontaneously. But stones that become lodged in the ureter may require lithotripsy or percutaneous or endoscopic removal. It's important to note that nearly half of all first-time stone formers will have another stone episode within the next 4 years. Recurrent stone formers are at even greater risk and may form a new stone every 2 or 3 years. But what actually causes crystals to form? Why do some crystals develop into kidney stones and others do not? One critical factor is supersaturation of the urine with stone-forming salts. Supersaturation is the driving force for crystallization. In undersaturated urine, crystals cannot form. The other important factor is a deficiency in substances called inhibitors. Inhibitors retard the nucleation, growth, and aggregation process by binding ions needed for crystal formation and growth. One of the most important inhibitors is citrate. Urine saturation and inhibitor levels explain why, in normal patients, large crystals are not formed. Their urine is not as saturated, and they have sufficient quantities of inhibitors present. But the urine of patients with kidney stones is more saturated. It may also lack inhibitors that increase the propensity for crystallization of stone-forming salts. There are two reasons for this. First, stone formers are known to suffer from a variety of metabolic disturbances that increase the amount of stone-forming substances excreted in the urine and also decrease the excretion of inhibitors. Second, a number of common nutritional and environmental factors can cause abnormalities in the urine. These factors may also exaggerate underlying abnormalities due to metabolic disturbances. Environmental stresses, for example, play a significant role in stone disease, especially factors that trigger excess water conservation in the kidney, such as inadequate fluid intake. Dehydration is a major cause of kidney stones, which is why people living in areas with high temperatures and humidity have a higher incidence of stone formation. A diet high in sodium is a double risk, because it increases calcium excretion and reduces urinary levels of stone-inhibiting citrate. Too much animal protein creates similar problems, encouraging stone growth by increasing urinary uric acid and reducing urinary citrate. Certain medications are also known to encourage stone formation or growth in susceptible patients, including common supplements such as vitamin C. There is no cure for kidney stones, but once an acute episode has been resolved, the key to therapy is simple: preventing recurrence. And fortunately, the most common stones, calcium oxalate and calcium phosphate, can be effectively managed with a combination of diet and lifestyle changes and medication. Compliance with proven management guidelines, such as increasing fluid intake and avoiding stone-promoting foods, can significantly reduce stone recurrence. Medical therapies, such as thiazide diuretics and potassium citrate, are also highly effective in appropriate patients and can reduce the need for expensive assisted stone removal procedures, such as shockwave lithotripsy, SWL. The economic burden of kidney stones is significant, with medical costs reaching billions of dollars annually. Effective management of this painful disease remains.
All right, guys. Any questions, folks? Okay. All right, moving on. So now let's take a look at the male and the female urethra. And again, the urethra is the final section, the final structure of the urinary system. before we pass the urine out of the body. And there are several differences between the female and the male urethra. Not only they differ in terms of their anatomy, but they also differ in terms of that physiology. So they have different function as well. The female urethra, folks, only belongs to the urinary system. Okay? Because the only thing that is going to pass through the female urethra is going to be urine, nothing else. And the female urethra only has one section only, and is about 2 inches in length. Now, the male urethra is quite different because the male urethra is much longer than the female urethra, is about 8 inches longer, but also it does pass it through different sections of the body. The first section of the male urethra is going to pass through a gland that we call the prostate, and we're going to discuss about the prostate in the next chapter, chapter 16. So the section of the urethra passing through the prostate is what we call the prostatic urethra. Then there is a little section of the urethra right here passing through the external urethral sphincter, and this is going to be called the membranous urethra. And then the final section of the male urethra, which is passing through what we call the spongy or the penile tissue. This is going to be the spongy or penile urethra. Okay, so in an exam, folks, you need to be specific in regards to the male urethra. If I'm pointing to the prostatic inside of the prostate, you need to tell me prostatic urethra. Am I pointing to the membranous urethra? Am I pointing to the spongy urethra? It's not enough just to say urethra. Okay? Now, this is the difference between terms of the physiology, of the anatomy. What about the physiology? Well, the male urethra not only belongs to the urinary system, but also belongs to the male reproductive system. Because not only urine is going to pass through it, but we're also going to have sperm passing through the urethra as well. All right, so it does have a dual function within the urinary and the reproductive system. Okay. Any questions? All right. What's wrong with this thing here? Hold on, guys. All right, so let's talk about micturition. And micturition is the act of emptying the bladder. And the act of empty the bladder is actually a reflex. When our urinary bladder becomes full, there's a lot of nerves on the walls of the urinary bladder, and those nerves, they're going to become, stimulated, and it's going to send a signal to the spinal cord, the sacral region, which is all the way at the bottom of the spinal cord. Then that region is going to send a signal back to the detrusor muscle in the urinary bladder, in the walls of the urinary bladder, and that muscle is going to contract. Also, we're going to have signals sent to the involuntary and the voluntary urethral sphincter, and they are going to relax, and we're going to be able to empty the bladder. Now, there are two different conditions that are related with micturition. One condition is called the urinary incontinence. The other one is called the urinary retention. Urinary incontinence is when we have an inability to control urine flow. What does that mean? It means like someone that they might pass urine and they don't even notice that they are passing urine. Okay, so they have no control over their voluntary urethral sphincter. And oftentimes, this has to do with either a reflex or a valve control. Okay, having problems with my mouse here. Hold on, guys. Second. And then we have the urinary retention, which is the opposite of urinary incontinence. In urinary retention, we have a inability to pass urine. So this is when you actually need to urinate, your bladder, your urinary bladder is full, but then you go to the bathroom and very little comes out. Okay? Oftentimes, urinary retention is due to an enlarged prostate. You know, we just talked about the prostate and the fact that there is a section of the male urethra passing through the prostate. So as males get older, naturally, our prostate is going to enlarge. And as the prostate enlarges, what it does is that it's going to constrict the prostatic urethra. And by constricting the prostatic urethra, it's going to make it more difficult to be able to pass urine. Okay? So urinary incontinence is something that is common in females mostly. And urinary retention is something that is much more common in males. Now, where do we find the fluid in our body? Guys, there's a slight difference between the amount of water in males and females. Males have slightly more water weight than females. And most of our water weight in humans in general is actually found intracellular, meaning inside of the cell. About 2/3 of the water in our body is inside of the cell. A lot of people think that most of the water in our body is in the blood, but that is not true. The water in the plasma actually is the minority of the total amount of water in our body, okay? 1/3 of the water in our body is going to be extracellular, meaning outside of the cell, and most of that extracellular water is going to be found within the tissue, what we call the interstitial fluid or the tissue fluid. Very little is actually found in the plasma. Now, what happens when we feel thirsty, though? Folks, when we feel thirsty, that is because we are losing water. Either you are sweating profusely, or you are dehydrated, or you are bleeding out. You have some kind of a hemorrhage. When we lose water, that is going to send a signal to the brain because we're going to have a concentration of our blood, meaning now the solutes in the blood becomes more concentrated. And all the way inside of the brain, in the hypothalamus region, we have a little thirst center. And within this thirst center, there are receptors called osmoreceptors that can sense the amount of solute in the blood. If the amount of solute in the blood is too high, that is going to activate the thirst center, and they're going to send a signal to our body, making us feel thirsty. And now we have to drink water. Very important to understand and to remember. Don't ever feel thirsty in order for you to start drinking water. Because if you feel thirsty, guys, that means you are already dehydrated. So don't wait until you're thirsty to drink. Drink water throughout the day, okay? So this way, you won't be dehydrated, you won't feel thirsty. So let's take a look now at what are the different hormones and the cascading reaction that leads to an increase in blood volume and increase in blood pressure within our body. Let's say that you are dehydrated or you are losing sodium, you have low level of sodium in the blood, or you are bleeding out, you have hemorrhage. So if you are dehydrated, if you're losing sodium, or if you're losing blood, that means automatically that you will have a low level of blood volume, okay? Low level of fluid, of water in your blood. When you have a decrease in blood volume, automatically we are going to have a decrease in blood pressure. Remember, I talked about this before. There's a direct correlation between blood volume and blood pressure. When blood volume goes up, blood pressure goes up. When blood volume goes down, blood pressure goes down. So if we had a low blood pressure, this is going to activate little cells in the kidneys called the juxtaglomerular cells. And these juxtaglomerular cells, we have talked about them before, together with another group of cells called the macula densa, they are part of what we call the juxtaglomerular apparatus. The juxtaglomerular apparatus senses salt and blood pressure. If the blood pressure is low, the juxtaglomerular cells are going to become activated. They're going to release a hormone called renin. Renin combines with a hormone coming from the liver called the angiotensinogen, and together they lead to an increase in another hormone called angiotensin 1. Angiotensin 1 is going to pass through the lungs, and the lungs are going to transform angiotensin 1 into angiotensin 2. Angiotensin 2 now has two jobs to do. Angiotensin 2 is going to cause the vasoconstriction of the arterioles, okay? And is going to cause an increase in the amount of aldosterone that is released in the body. Now, what happens when the arterioles become constricted, guys? That alone will help to increase the blood pressure, bring the blood pressure back to normal. Now that in combination with the release of aldosterone, remember, what does aldosterone do? Aldosterone tells the kidneys to hold on to the sodium. And when the kidney reabsorbs sodium, instead of letting it go, the kidney will also reabsorb water because water follows solutes. So the release of aldosterone by the adrenal cortex leads eventually to an increase in blood volume. And an increase in blood volume together with the vasoconstriction of the arterioles will lead to an increase in blood pressure. Okay? Bringing the blood pressure back to normal. And this is the cascading reaction that's going to happen in our body when we are either dehydrated, losing sodium, or bleeding out. Any questions, guys? All right. Now let's take a quick look here at the regulation of blood pH. And remember, regulation of blood pH is one of the main functions of the urinary system. Okay? And there are three main buffer systems that help to control blood pH. We have what we call the bicarbonate buffer system, which is the most important one. We have the phosphate buffer system, and we have the protein buffer system. In the bicarbonate buffer system, what happens is that if the blood becomes too acidic, bicarbonate that we have in the blood, HCO3 minus, is going to bind to the excess hydrogen ions, to the excess protons. And that is going to bring the level of the pH of the blood back to the homeostatic level, which is between 7.35 and 7.45. Okay? Now, if the blood becomes too basic, now we're going to have carbonic acid, which is going to dissociate, meaning that it's going to break down, and in the process is going to release hydrogen ions, and it's going to bring the blood pH back to the normal level. In the phosphate buffer system, we have HPO4 2 negative, and which is a weak base, and this can bind to hydrogen ions when the pH drop. And there's another chemical also based on phosphates that is going to release hydrogen ions when the pH rises. And finally, for the protein buffer system, proteins have amino acids, and those amino acids, they can either accept hydrogen ion and act as a base, or they can donate hydrogen ion and act as an acid, depending on what is needed to maintain the blood pH. Okay? Super, super important processes that we have within our urinary system. Now, finally, taking a look at the development of the urinary system, because the urinary system is so important, guys, not just to filter the blood and produce urine, but also maintain blood pH, maintain the level of electrolytes, etc. Our urinary system develops very early on during the process of fetal development. Now, it's not going to be until the baby is already born, until the age of 3, 4, and 5, that's when our kidneys actually become fully mature. So even though it starts developing early, it doesn't mature fully until we are already born, until we are, in an age of 3 to 5. Okay? As we get older, we're going to have a decrease in the tone or the strength of the detrusor muscle within the urinary bladder. And also, we're going to have a shrinkage of the size of the urinary bladder. And if we have a smaller urinary bladder, what does that mean, guys? It means that you're going to have to urinate more often. And one of the things that's going to happen when we get older is that we're going to have a condition called nocturia. What is nocturia? Nocturia is when we have to wake up in the middle of the night to go to the bathroom, urinate. Okay? As we get older, we are going to develop more of the nocturia, again, because of decrease in the bladder tone and a decrease in the size of the urinary bladder. Any questions, guys? All right, so we have another chapter in the books. Folks, we only have one chapter left, almost at the end of the semester here. And so the quiz, I should remind you, the quiz for chapter 15 is open right now, and you have until Sunday night to take that quiz, okay? Have a great rest of your day, and I'll see you guys next week. Thank
Thank
you.
you. Mommy, finish your homework.